My name is Anthony Miru. I'm from the National Treasury, the GF Program Monitoring Unit at the National Treasury. So the National Treasury is the principal recipient one, or the state PR, and as the KCM presenter had said, we normally have the grant has the state principal recipient, and then we have the non-state principal recipient. So the National Treasury here represented is a state principal recipient. So our sub-recipients, again, for the PR, we do not implement the grant activities. We usually do this through the sub-recipients. And as somebody had alluded before, we used to have, we normally concentrate on three disease areas. That is HIV, TB, and malaria. And our principal, our sub-recipient for this matter is the Ministry of Health through the various divisions. For example, we have the TB unit at the Ministry of Health, and then we have the HIV, that is NASCOP. Then we have the Division of National Malaria Control Program. And of late, we were added one more sub-recipient called the HSSD, that is the Health Systems Strengthening Department. And then the other sub-recipient is National AIDS Control Council. And then, I'm just giving you an overview of how things look like for the state PR. We also have a procurement agency. We have an MOU with the KEMSA because most of our funds as a PR goes to procurement of commodities. So KEMSA, we have an MOU with KEMSA, and they do procurement on behalf of the National Treasury. Next slide, please. So this is how I'm going to do my presentation. I'm going to show you for the current grant, it is called the new funding model 3. We used to have rounds of grants, but the rounds ended, and then we started the new funding model 1. The last one that ended in last year, that was 2021, was the new funding model 2. And then from 2021, I think, until 2024, we have the NFM 3. So when you hear me talking about NFM, just know it is this current round of grant. But I'll still show you a snapshot of what happened in the previous NFM 2. So this is the way I'm going to do my presentation: programmatic, then you'd go to financial, and then a brief of the procurement and supply chain management. And then I'll show you some of our PR oversight activities, and then some of the key challenges and the mitigation measures that we have put in place. I'm not sure I'm going to read all these, but in a snapshot, I just wanted to show you. I'll start with the HIV program. So this is for the period between June 2021 until December. We call it a semester update. And you can see there are key indicators that we were being measured on by the Global Fund. So when we are doing our semester report, there were targets that were set for the performance framework, and specific indicators for the same. I'm not going to go through each one of them, but you can see how, for example, for the HIV program, how the performance is. And this is what happened until December, for the period of 6 months until December last year. But if you want the specific details, I think I've shared the presentation so that I don't take a lot of your time. Next, please. Again, for HIV, other indicators like PMTCT indicators, number of VMMC and the challenges, because at the comment section, if an indicator is performing below, we will tell you why. If an indicator was performing above, again, we are able to go to the DHIS and tell you why this perform. Okay, because most of our data here is coming from routine data. So you go to DHIS and you will confirm that this is actually what was happening. But then in the comment section, we try and explain why if an indicator was performing below or it was overperforming. Next, please. For TB program, these were the indicators that were being tracked, like for example, the case notification rate, percentage of health facilities with treasure medicines for the 3 diseases, and the like. Again, I'm not going to go through, the presentation is there, but you can see at the comment section, if you see the results, we have explained why the performance was like that. Next, please. TB continued. The next. So for malaria, again, these are indicators that are being tracked. For example, confirmed malaria cases, whether it is microscopy or through RDTs. Again, the results, and then the comment section. So basically, these are the indicators that were put in this grant, that the NFM3, for the next 3 years. And this is what we are being tracked as performance in the performance framework. So next, please. Then in summary, this is where I wanted to come because I didn't want to go through each and every grant. For example, in HIV grant, the key issues that were noted during the last semester is that we had erratic availability or stockouts of commodities. And then there were funding gaps, especially for VMMC, that is voluntary male circumcision. And then there were gaps again in patient-centered care. So there were a large number of lost to follow-up patients. So again, for each and every issue, we have given a mitigation measure. So what is being done to improve the performance where we felt there were critical gaps? For malaria, I want to touch on this issue of frequent stockouts of essential commodities. These were ALs and RDTs, and I want to explain that for malaria program and even the HIV program, the pipeline is a product of different key players. For example, there is the US government and the Global Fund. It is not only the Global Fund that contributes to the pipeline. So we had issues across board with the USAID funded commodities whereby they didn't have tax waivers for their commodities. This has since been resolved. And then if you look at the pipeline as it stands now, it is very, very full. And we are happy that the US government was able to get that waiver. So we have 2 pipelines, for example, in malaria, where commodities that are coming through the USAID funded commodity through PMI, they are being channeled to meds. They changed from KEMSA, and then the Global Fund granted commodities are coming through KEMSA. But you see the user is the same. So everything is coordinated by the program such that we don't have any gap. So for facilities, they don't know whether this comes from USAID or this comes from Global Fund. What they do is to request for commodities because these are demand-driven commodities, and then they are channeled to them accordingly. There is a logistician who does that. Next, please. So if we go to the finance performance, basically I want to show you how we performed in the previous grant. And generally, you can see in terms of absorption of funds, the HIV program was able to get a 93% absorption, which was very commendable. TB, 91%, and malaria, 94%. If you look at the total grant budget that Global Fund had availed, this was 310, 963, 578 US dollars. So compared to the expenditure, which was 288, you can see generally Kenya was able to do 93% grant absorption, which to us is an improvement of the previous grant. Next. So again, this is now in the new grant for the previous 6 months. You can see that if you look at absorption in terms of budget versus expenditure, you can see that in HIV, the budget for that specific period, that was 6 months from June, the budget was around 2.4 million US dollars. But then the only expenditure was 851,812, which means that if you compare expenditure versus budget, it was coming to around 36% for the first 6 months. But if you include obligations and commitments, that is funds, the contracts that had been signed, and again, there are invoices that we have already received at the National Treasury, which were not captured, because you only capture expenditure when payment is done. But there are invoices that are there, that is what we call obligations, that have been forwarded. Then commitments is anything that has been contracted and that has been awarded. So if you look at like HIV, you can see there was a 729% absorption, and most of you will ask why. But this is because HIV were able to procure, to bring forward the year one procurement within the first semester, and that is why, against of their budget, they were able to bring a lot of procurements which were delivered, and they are being processed. The payment is being processed. So again, if you look at TB and malaria, we can talk about 77% absorption of funds for the first 6 months, and then for TB, 36% absorption. Next, please. So basically, this is what I was explaining, but graphically, that is budget versus expenditure versus commitments and obligations. Next, please. So if you look at, again, if we want to sum up the financial performance, the HIV, you can say that absorption as December 31st was at 36. But if you look at the contracts, which amounted to 36 million US dollars, they had already been signed by the end of December, and deliveries amounting to around 16 million US dollars had already been made. These are largely procurement of adult and pediatric antiretrovirals. Then TB, again, it was at 24%, with commitments of around 0.6 million US dollars. Then for malaria, again, if you look at budget versus expenditure, it was at 35%, around 36. And then there was a mass net distribution exercise, which was being paid from the NFM3. These had already been completed by December, but it had not been captured as expenditure. Again, if you capture that, the absorption again goes very high. Next, please. I want to touch briefly on procurement and supply chain updates. Next, please. If you look at NFM3, we were able to start procurement of, for example, for malaria, of around 2.6 million US dollars. They had already been contracted, and deliveries, I believe, will start trickling in by the end of this month and in April. Again, rapid diagnostic test kits worth around 10,000 US dollars, which we expect in the month of May. Next. TB, the same story. You can see what has been contracted. And again, this is the status. Some have been delivered, some have been contracted, and some deliveries are ongoing in stages, which sometimes are staggered. Next, please. Then ARVs, against a budget of that, you can see the status, like TLD has been fully delivered, other 3 items have been contracted, and the like. If you look at things like condoms, worth 2.7, they are contracted, and the deliveries are expected in May. So generally what we are saying, we are on course in terms of supply chain management or or procurements. Next, please. And then the same story for other commodities in HIV. What I want to say is that for some items, some are being reevaluated, like the opioid substitution medicines, and then the reevaluation has already been completed, and we hope the process will continue normally. Next, please. Through Global Fund, again, there's something I didn't mention in the beginning. The country is supposed to contribute 20% of what Global Fund gives you through counterpart funding. And this is a status. And for TB, they had a budget of 250, 761. This is for the period between June 2021 to July 2022. So these commodities were at contracting stage. For malaria commodities, most of them have already been delivered because I had made this presentation earlier, but I know most of these commodities have been delivered. And then for HIV, with a budget of around 1.4, I think most of the ARVs are at notification stage, and the male condoms are at evaluation stage. Next, please. I had told you that we have an MOU with KEMSA because they are the ones who does our procurement. So we had to review the engagement, the MOU, and the status is that the MOU has already been finalized and has already been submitted to the Office of the Attorney General for legal clearance. And then KEMSA have developed a tracker whereby we will be able to determine performance against the key performance indicators. And then most of these key performance indicators are related to timelines of procurement. Next, please. This just shows you how everything is progressing in terms of submission of the year 2. We are in year 1, which ends in June, but you can see we want to be ahead, and you can see that we want to start the procurement of year 2, and year 2 is starting in July, but already if you look like for malaria, they have already done the quantification. It was already done in September. So the supply plans have been developed and submitted to us for review. So we want to work way ahead of time so that we don't have, because of the lessons learned, we learned from the previous grant. Next, please. COVID-19 procurements. Again, these were the allocations because Global Fund, when COVID struck, Global Fund said that we cannot be able to tackle the 3 diseases when we still have this issue of COVID. So they were good enough, and they granted this allocation to the country. And again, this is the status of these procurements that were awarded by Global Fund, specifically for COVID-19. Next, please. The same story. Next. Next, please. Yeah. HIV, yeah. Just go ahead. Some of these slides were for another forum. That is why they are so much detailed. That is why I'm skipping some of them. PR oversight activities. We are saying that as a PR, we have an SR, and our SR is a Ministry of Health. So we have to monitor how the malaria program is implementing the activities according to the grant document, how TB program is performing, and how HIV program is performing. So we have developed a schedule. Like, we have a monthly meeting every month with the program and see how we compare what they're supposed to have done and how far they are with all the activities. Yes. So again, I've talked about that. Next, please. Then if you look at what we have already done, like here you can see, Procurement status, we have already gone to KEMSA once. That was in January. If you look at the SRs, we have visited the HSSD. This is a new SR who needs a lot of support because they were not there previously when these other programs were there. And National Malaria Control Program. In terms of financial management, you can see where we have visited. And again, for KEMSA, again, we have been there once. That is since January this year. Next. So, these are some of the key performance challenges, like numerous competing activities among our personnel. So sometimes we have routine engagement with SRs and KEMSA. We also have our internal PMU administrative tasks and activities by other stakeholders, including KCM, which we work very closely with. So sometimes, what are some of the next steps is follow up on action areas that identify and improve on adherence to the oversight schedule that I had shown there before. Next, please. So the key challenges, generally or overall. Next, please. So some of the key challenges in the programmatic activities were slow implementation of programmatic activities, and then almost no programmatic activities were implemented in NFM3 Q1 period for all the SRs because we had delays in disbursement of funds from Global Fund. So most of the activities were not conducted. And then operationalization of the HSSD has been slow. This is a new SR. So again, we are trying to see how best we can support the department so that they're able to catch up. And then the other key challenge is the sub-recipients and the MOH yet to involve counties. We said at the beginning of this implementation period, we were to separate the county level activities specific to counties. We share with the counties so that all the SRs should share their work plans with the counties so that, again, the counties can start implementing what they're supposed to implement. That has been slow, but I know we are on top of it. We are trying to push the SRs so that they're able to incorporate the counties in their specific county activities. Yes, next. Is there anything else? Yeah. So some of the achievements, we can say the tax exemption master list, that is a must because Global Fund commodities or activities are supposed to be tax exempted. That one we have already been able to get. And then COVID-19, delays in delivery of commodities by month due to requirements for PVOC registration. These already in year 3, in NFM3, this has not been the case. And then we have increased the capacity of accounts department through secondment of accountants to some of our SRs because that has been a challenge in the previous grant implementation. With that, I want to stop there and ask if there are any issues, questions, clarifications.
Good afternoon, everyone. My name is Kenneth Ogendo. I work for Living Goods Kenya, and pleasure to be here. And that's indeed a great presentation on how Global Fund is supporting this country. Last time I checked, and I'm asking this question because I can see you are from Treasury. There was a call for Kenya to adopt the call to self-reliance. And I have also seen a slide there on co-financing. So to what extent is the Ministry of Health and the Ministry of Finance or Treasury planning to transit Kenya into that direction? What are the conversations and how prepared is Kenya for handling HIV, TB, malaria programming? Where are we at that? Thank you so much.
Thank you. You have partly helped me to answer that question, that one of the key inputs that the government has done through the National Treasury, which is a requirement by Global Fund, you can see over the grant periods, the government has been kind enough to have increased the core financing for this country. So if you look at the previous NFM and the current NFM, the government has really increased the money going to the county counterpart funding. The other bit is that the Ministry of Health, through their MTEF, have been very keen, and we have seen that for TB, I think even for malaria and HIV, they have set aside a budget to support these 3 programs, which is a departure from the previous periods. So if you look at the MOH budget, and I think they had even called their staff for a workshop to really come up with the needs and what the government can support, again, through the Ministry of Health. Again, when we meet counties, we really encourage the counties to take up some of the traditional activities that were being financed by Global Fund. So by involving the counties, we have seen a lot of counties that have set aside money to support disease areas, not necessarily procurement of medicine and the like, even in terms of staff, employing staff where probably there were HR issues and the like. So I think through these 3 areas, I think we are moving towards sustainability.
Thank you, my brother. My name is Meshak Ndolo. I work for IQVIA, a global health consulting entity that's a member of KHF. I just wanted to ask something very briefly about the absorption rate. And when I look at the figures that you shared, 24% I think for malaria, TB, HIV, somewhere between 35 and 36. My mind goes into how as a country we can work together, both public and private sector, to improve the absorption rate of the Global Fund. When it's at that level, definitely there is concern, considering that this year we are very busy. We have a busy year, getting new leaders, so sometimes these activities, they tend to slow down implementation of public health programs. So I'm just asking 2 questions. One, are those figures for both commodities and service delivery in terms of absorption, or are they only for commodities, or are they only for service delivery? Because we do know that about nearly 80% of the Global Fund money goes to commodities. So I'm looking at the question of how can you disaggregate the absorption rate in terms of those 2. The other question in terms of now working together as public-private sectors is, having disaggregated which figures are in which of those 2 categories, then because from where you sit at the National Treasury and Planning, you have big eyes. You see things from very high level, because you are very organized in terms of being able to capture data from many fronts. How can we, as private sector, benefit from some of the data you have that's pointing toward the direction of where there are weaknesses in terms of absorption? Is it us in private sector who are not supplying what you need quickly when you need those commodities? Or is it you who is not, as public sector, having a good plan and roadmap that can anticipate the timelines where commodities are needed and they should be delivered, and you get caught up? I'm just asking one question. It's a very small question, although I'm saying with so many words. Thank you.
Okay, thank you very much, Mr. Meshak, for that feedback. I'll start with the issue of absorption. If you look at those figures, where it was low, it was when it was just expenditure versus the budget. Meaning, whatever had been paid by December versus the accumulated budget for that period. But if you looked at the end, I was putting something called obligations and commitments. For example, I'll give you a very good example of malaria. if you look at the absorption at I think 34%, that was what was expensed, what had been captured in the books by December. However, we had very huge contracts that had been signed by December for procurement of antimalarials. And other obligations means there were so many invoices that had been brought to the National Treasury that had not been paid for, but we could not capture them as expenditure. So when we combine expenditure and obligations plus commitment, the figure again changes, and I demonstrated that. The same for HIV. That is why the HIV, when you put commitment and obligation, it was coming to 729%. Because what the HIV program did, they were able to procure ARVs within the first year. They were able to bring forth the budget, and most of these commodities have already been delivered. So we learned from the previous grant not to be waiting for example, if the budget for year one has been put towards the end of the year, like for malaria, we had already submitted that by July to KEMSA. So by December, they had already done the contracting. So maybe the picture will look better when these deliveries are done. Like for antimalarials year one, we are very sure by end of April, we'll have all the commodities in place. Again, to add on your second question, yes, it represents both procurement and services. Because in the first quarter, basically, except for the malaria program where we had mass net distribution countrywide, for these other programs, since we didn't have a lot of activities, we had foreseen that, and we didn't put a lot of activities in quarter one. So basically, the only absorption there was the normal salaries and things to run the program. But we had not put key activities in the first 3 months because of the lessons learned in the previous grant. Very important is the issue that you have brought forward for public-private, and I know you have been in this program and you have a wealth of experience in it. So if we critically look at the grant documents, the grant document has activities or modules, specific modules with specific activities, and if it is procurement, I think that is an opportunity, as you have said, because what KEMSA does or what MEDS are doing, they do international open tender. And I think, I'm not sure, there is somebody who was here, the gentleman from Kiku, who said they lost a bid because of, I think, 0.5 or something. So when you have an international tender, I'm not sure, maybe I heard Margaret talking about bringing on board some of the private sector on board to be part of, because I don't know, when an international, tender issues are very sensitive. So once it is put in place, I think they go for the lowest. But I don't know whether there are measures that the Kenya government can put so that they can, for me, I feel you can encourage our own industries or local mechanism. But I think that is something that should be looked up to, because again, I guess it is because of economies of scale that some of these small private entities are marshaled out of the competition. But I guess it's an area that can be explored and needs a lot of thought to it.
Thank you very much. My name is Andrew Nyandigisi from Health Strat, a member of KHF as well. Thank you, Anthony, for the presentation. It's quite clear and useful, and excited about the progress that has been made. On to my question in the interest of time. I think the question I think Meshach is asking is quite critical about the commitment of funding that goes towards our absorption rate, and I want to specifically touch on supply chain, on the deliveries. One of the biggest headaches I remember that the government used to grapple with is an issue of proof of delivery. When to show, before the Treasury could pay KEMSA they needed to confirm that the commodities that they were tasked to deliver had actually been delivered. And I remember what used to happen is a huge consignment of paperwork would come to the programs, and somebody had to go through them to confirm that the delivery had happened. And I think this is an area that used to cause a lot of delays and therefore affect our absorption. My question is, what has been done to address that? Because as I speak, I do know that there are other technologies that have been actually developed that donors like World Bank, UNFPA are actually using to confirm deliveries at the facility level in real time. Is this something that the National Treasury has looked into? Because then it can shorten the turnaround time and also reduce a lot of the audit queries that otherwise follow such a confirmation. Thank you.
Thank you. I think I'll just point of clarification. When we said we were 0.5% more expensive, is because of the RDL and GOK that we are supposed to pay on import of raw materials, whereas the imported product gets full exemptions. So if we did not have to pay that to make it a level playing field, we would have been cheaper than the imported product. So it's not economies of scale, it's definitely our own taxes, which are not a level playing field against the imports. Thank you.
Okay, thank you very much, Andrew. And thank you for the clarification on the 0.5%. And the proof of delivery, Andrew, I'll tell you, I think the only thing has been done so far is just to have that acceptance and inspection committee that when the goods are delivered, they go to KEMSA, now from the ministry, and then they ascertain that those goods are there, such that when the paperwork to the head of the program, it is just a matter of him calling his committee and saying that these things are there. Because again, you know, for government, government is a bit bureaucratic, sometimes even with paperwork. But I appreciate that if there are opportunities whereby even KEMSA can be supported or other procurement agencies, I think this is the way to go. Yeah, I think this is the way to go, because even some of these bureaucratic systems we had, like now we are using M-Pesa even at the National Treasury. So I guess it's an opportunity, and it is something that I guess people who have that experience can bring forth, and we see how best this entity can be assisted. So it's a welcome idea. Thank you.